I'm Julie Carter, and I'm a nurse practitioner at Oregon Health and Science University, and I'm here with Jane Nutt, who I have worked with for 35 years. And we're at the 19th annual Movement Disorder Society International meeting in San Diego.
Well, Julie, 35 years, that's something to talk about. Why don't you, I'll talk a little bit about myself in a moment, but why don't you just tell me how you happened to be there when I arrived at OHSU and we started working together in the end of 1978?
Well, I just done my graduate work in nursing and was always interested in neuroscience from the day I could remember. And as I was going through graduate school, it was a bit unusual for a nurse to be interested in neuroscience. And our colleague, John Hammerstadt, kept encouraging me to join him when I was done. And I was on nursing school faculty for a while, and he kept talking to me about this idea and said that there was a young neurologist coming from NIH, and he thought it would be a fabulous team if the three of us could work together.
And that indeed is right. So let me just fill in a little bit about sort of my background and why I ended up going to OHSU at that point. So in college, I was always interested in the brain and the way the brain drove behavior. And I was actually very interested in drugs and the way drugs could affect the brain as well. And so going to medical school was an obvious next step, and in medical school I also got a master's in pharmacology because, again, I liked pharmacology and the way you could learn about behavior from looking at drugs and the way drugs affected behavior. When I finished medical school, I did a year of internship, and then I spent 2 years at the National Institutes of Health, which was in Lexington, Kentucky, or part of it was, where they were doing addiction research. And there I was part of a unit that was doing clinical drug trials in actually prisoners. They're prisoners that had a long history of drug abuse, and looking at drugs and their effects on mood and behavior, and that was actually wonderful clinical training. And after that, I did a neurology residency in Seattle, and then went to NIH, and it was from NIH that John Hammerstadt, the person that Julie just mentioned, recruited me as well to come to OHSU. So what I recall about those first meetings was you were also in the constant headache clinic. Can you tell me a little bit about that and how that fit into your career plans?
Well, again, Dr. Hammerstadt, when he recruited me to start a movement disorder clinic with you and one other nurse practitioner, actually, he also asked me if I would work in the headache clinic with him.
I thought it was the constant headache clinic.
We affectionately adopted that name because there were constant headaches that came to that clinic. So I think that fit into my career plans by identifying something I would not want to do my whole life.
Well, that's helpful. So I guess one of the other things that I might comment on is how I came to OHSU. And at NIH, there is almost every expertise represented. There are all sorts of equipment. It seems like you have everything you want. And on leaving NIH, I thought, well, I'm leaving all that behind, and I will disappear into the hinterland. And I think one of the things that turns out to be very important is wherever you go is developing colleagues that you can, that share enthusiasm, hopefully about the same things that you share enthusiasm for, and that you can develop things with relatively little in the way of resources. And so for me, going to OHSU, finding John Hammerstad, who was a wonderful clinical mentor, he's the one who really did all the administrative work that made it possible to get clinics and so forth. Meeting you and getting involved in caring for patients. And Julie is actually the person who finally convinced me that there was not a drug that was an answer for every problem that a patient had, that there were other things that were important as well. And then there was another person in the department who was a neurochemist, Bill Woodward, who said, if we want to do something with levodopa, he would set up an assay and could measure it in blood for us. And it was that combination plus a good clinical research unit that really got us into doing research on levodopa.
So what do you think, when you look back over all these years, are the biggest accomplishments that you've made? And one of them is this idea of levodopa, and just say a little bit more about that.
Well, levodopa at that point was a marvelous drug, but the phenomena of the on-off, the motor fluctuations and dyskinesia was emerging and was a major problem. But also there was the feeling that these complications were somehow unrelated to when and how you took levodopa. And as somebody trained in pharmacology, I thought that can't be. And so it was partly trying to give some pharmacological basis to both the clinical response, what we're after, the anti-Parkinson's response, and to understanding the fluctuations in the dyskinesia was and remains a great interest. I think we've made some progress, and I think most people think that there is a response between taking a dose of levodopa and how these complications and the motor effect take place, but there's still a lot to be understood. I think the other thing that has been a major interest, in the other place where I think I've made some contribution, is on gait and balance. And gait and balance used to be basically just a clinical sign that was used for making diagnoses, but wasn't really used in any other way. And I think thinking about gait and balance, how gait and balance can go awry, and working out a way to at least think about these problems has been another thing that has been really fun. But let me turn back to you, Julie.
Before you leave that, though,
Yeah.
I want to make an observation that I think is one of the secrets of your success in science, and because I believe all the dots are connected, and so I think it's also a secret in your personal relationships, and that's that it's your curiosity. And I think that you always are more interested, I've told you this before, you're always more interested in what you don't know about something or somebody than what you do know about them. And it makes you really open to, differences in people and differences in your observations. And you don't expect that you know what it is that's happening or who a person is when you meet them. So I think that's a wonderful attribute, and I think it's affected all aspects of your life. And I can say that because I've watched you for 35 years.
Well, thank you. So Julie, what did you see as the turning point in your career? I'll tell you what I think it think it was, but what do you see as the turning point that made you focus on Parkinson's disease?
You know, I actually think I sort of grew up. When I was a graduate student, and when I was a nurse, before I was a nurse practitioner, I really wanted to be in neurosurgery. And I loved the action and the quick decisions and the sort of excitement of critical care. And then I realized that what really matters is how people, what brings them a sense of well-being and happiness. And I think or just contentment, or whatever that word might be. And I think in chronic degenerative disease, you have an opportunity to really help people and guide them in whatever they identify as that. So I think I grew up. And I also think I was very much influenced by working with a group of people who were so collaborative. So I was very happy in the work environment as well as the population. So what do you think my turning point was?
Well, I think the turning point was when we got a grant to develop a Parkinson's Center. And the idea of actually being a center, and I think that is what first really excited you. And then you had the vision, John Hammerstead and I didn't. You had the vision of creating a team that worked out, that reached out to other subspecialties and to allied health care and so forth, and to the patients themselves, to help themselves. And I think the first center that we had was the step that really led you into that. And I think the rest of your career has been developing new ways of treating people with Parkinson's disease. Up to that point, I envisioned my career as new drugs to answer each problem.
Well, I think that's one of the sort of more generalizing that. I think that may be one of the best things that's happened in the time that we've been in our career, is this true appreciation of other disciplines and the contribution they make to care, and then working collaboratively with them. And we were both sort of grew up in this era where doctors were here and nurses were here and everybody else was here. And I think what you and I often said to each other is we're really additive in care rather than one person is better or worse. And so I think that's been true. And as I look around, especially at a conference like this, that's so alive and well. I mean, it's still in its infancy, but I think it's definitely happening. A mutual recognition of the value of other disciplines and their contribution to the care of people with movement disorders.
I think that's true. I think this meeting is really, it used to be just neurologists, movement disorder neurologists, and now it really is reaching out to a great variety of people that have something to do with the care of movement disorders. So who do you think the role models or heroes in this field have been for you? Who have been influential people?
You know, I don't know if I would say that I have a certain role model. Influential, I think, have been, I have to start really with you and John. I think you both gave me an opportunity to, sort of an unleashed opportunity to be everything that I possibly could be. And when I actually didn't think I could be it, you encouraged, you believed in me, even when I didn't believe in myself, and allowed me to just sort of do all the things I could do. So that you certainly have been very, very good mentors in that way. So, but nursing-wise, I really haven't. I have felt a bit alone in terms of finding a nursing mentor in this particular field. But hopefully, I've been a mentor to other people along the way. How about you?
Well, I think you get models for different reasons. Actually, it was Stan Fawn who told me how to start a center. He said, you just go someplace, you tell them that you're going to do movement disorders, you get a couple of drug trials from drug companies, and you're off and running. And,
pretty much did that.
And that was, and I followed that advice. So that was very good advice. David Marsden was a brilliant person, and probably my most important paper on gait was the paper I did with him and Philip Thompson. And what David had an incredible knack for was putting things into terms that both excited the reader and gave the reader something to carry away that was very, very simple. Gait ignition failure was a term that David Marsden came up with, which was really excellent.
I remember when he came to visit Portland. Do you remember it?
I do.
Mm-hmm. Yeah.
And that was a great visit, and that is where I talked to him about intravenous levodopa. That I thought that was going to be the answer to understanding the on-off phenomena, and he agreed, and went back to London to do it with Neil Quinn as well. Mm-hmm. So we were both doing it simultaneously. So. What role has the Movement Disorder Society played in your development and your career?
Well, I think that it's always a place where I get excited about new ideas, and so it's obviously a forum where everybody is interested in the same subspecialty versus a larger meeting where you know there's all kinds of neurology going on. So I feel like here I've had access to a lot of people who are interested in Parkinson's disease and movement disorders. So it's always engendered a lot of excitement, and I often leave this meeting with a long list of things that I would like to do when I get home, and it's also given me access to again, this health professionals special interest group is again in its infancy, but it's growing, and really being part of an organization that is becoming inclusive of all disciplines has really been, really instrumental and an instructional thing for me. So what about you?
Well, I think it's tremendously invigorating to come to a meeting, and some of the talks are spectacular, but I think what I most like is talking to people, and sometimes you talk to people, they give you incredibly good ideas, or they bring out things that you'd never thought of before. So I really enjoy that aspect of the movement disorder field. But it's also great to see the organization growing, that there's now, seems to me like a huge number of people who are young and vibrant and really trying to offer better care to their patients. So I think that's really the part of the excitement for the meeting.
Since we're doing this for the archives, I guess we have to admit to some of these things, but being older. But I was having lunch with a group of young physicians about palliative care, and I was struck by, they were all so excited about what they could contribute to late-stage disease. And those things were not drugs, but they were about good care and alternative care and compassion and also the science around some of those things that would be thought of as sort of fluff when we started this career. So I guess that's a very exciting thing for me, and it's fun to see the sort of the shift and incorporation of all kinds of aspects of care in young physicians.
Mm-hmm. So Julie, you've been a developer of new kind of programs or activities or such for as long as I've known you. I remember the first thing you developed was a pallidotomy clinic, which shows how long ago it was, trying to more efficiently evaluate the patients and tell them what pallidotomy was really about. But of all those programs, which are the top 1, 2, or 3 of the programs that you've developed?
I think that just in general, the fact that our program really has, all 3 legs of a 3-legged stool firmly in place is really we have really strong care, we have really strong education, and we have strong science. And I guess, so that in general, I'm number 1 proud of. But probably the programs I've done that have, in the newly diagnosed arena, that has been sustained since 1995 and does...
And can you just remind whoever might be listening to this what the newly diagnosed group is?
It's a workshop for people who are newly diagnosed, and it's a small group, maybe 5 couples. They usually come as a couple, they don't have to. And it's run by myself and 2 patient and wife who are both educators and have lived with PD for a long time. So they present, besides being educators, a very inspirational picture of how you can live. And it's it's a dynamic kind of format where people get to ask the questions they're interested in knowing the answer for, rather than us telling us what we think they should know. And it's I feel like it's one of those situations that you give so much hope, encouragement, and a plan for the future in a situation where they feel like their whole future has been sort of shattered. So that, I think also a couple of recent, the work I've done around caregivers, I think has been hugely important for me, and I hope for the field. And then the other...
And to be more specific, your work with caregivers includes both research that's published as well as programs to support and help caregivers.
Right, yeah. And so...
I still know a little bit about what you do.
And I think the third thing is just really going through it seems only fitting that as I go through this career, I end up developing palliative care as the last program, and just developing this palliative care clinic that I think that there's all kinds of sort of offshoots of that could and should be done to really improve the care in our program across the continuum. So what about you? What are you most proud of?
Well, I'm proud of a lot of things. I mean, I'm proud of our program, and I think that what our program has done, and since you and I have been the real sort of drivers of the program, I think what we've done is really surrounded ourselves with excellence, and we have had some really top-notch research assistants. Many have gone on to either into medicine or PA school or things like that.
Mm-hmm. Absolutely.
We've had lots of fellows, and I think the fellowship program has been a real boon to our program in general. And many of them are inquisitive. They branch out into new areas. I think that's great. And I think our faculty, which continue to grow, but are also are good people, and everybody is dedicated to really trying to offer the best care. And the best care is not just accurate diagnosis and skillful use of drugs. I mean, there are lots of other things that are equally, if not more important.
So what do you think is some of the most important advice that you give young physicians as they come through our program, or just in general about their career?
Well, that's an interesting question. See if I can come up with an interesting answer to go with it. I think that part of it is trying to get the fellows to try a lot of things. We want them to try research. We want them to try other aspects of care. And I think also giving them the information basically that Stan Fawn gave me, which is you can find collaborators, you can find people to do things with, and you can find an institution that has some strengths that can help you, and that is really up to you, and you shouldn't feel defeated. And our fellows have gone into all sorts of different things, and in fact, one of our fellows who did movement disorders for a few years and then shifted into palliative care. And her research project as a fellow had to do with palliative care. So it was kind of a natural transition.
Yeah.
So I think it's, and I think the other thing is having the fellows leave our program feeling like they have been well trained. They have seen lots of clinical things, they have experience, but they have experience in other areas as well, such as research.
So many, I think there's been a shift in the number of women that have come through our program than when we first started, and there's been a shift in what I think the conflict about work-life balance is greater than, at least I'm more aware of that struggle in young neurologists and physicians in general. What do you think is good advice about having a good work-life balance? You have to make sure you're the right person to answer that.
Well, that is a point. I think my work-life balance, now that I'm half retired, has finally reached a better example.
I'm not kidding. You've always had a good work-life balance, I think.
But I think, I think that you need to make sure that you have other things that are important and interesting for you, and that while you're doing them, you can do those without thinking about work or being constantly concerned about what's going to happen at work the following week or what happened last week. And be that activity with your family, be it in sports. But I think you have to be able to shift and do something other than work for a portion of the time, and learn to leave work behind when you're going to go do something else. So Julie, as a nurse practitioner, and I remember coming to OHSU and not knowing exactly what a nurse practitioner was. I did know what nurses were supposed to do, but I didn't know what nurse practitioners were to do. But what kind of, being a nurse and a nurse practitioner in this field, what kind of barriers do you think you've faced?
Um, well, I think when I really do love research, and I think that there were barriers around being able to do research. I think I persisted and did some, but there are definitely doors that are closed to you. And so I know that I made this transition from being a drug study coordinator to being an investigator, and which was really really fun, and feel like I was able to do a really good job of that. But certain industry would not even consider that a nurse practitioner had the legal ability to do that, when in fact they do. So that, I think, was a barrier. The other barriers are just, I think sometimes being able to be self-determining in how you want to make a difference. But I think everybody encounters that. You know, you have to just believe that you can forge ahead and put together the right justification for whatever you want to do and move forward. I guess I think that's somewhat a personal issue rather than a professional issue. I think just early on, being a nurse practitioner and managing patients with outside providers, it was still a relatively new role, and you had to prove yourself rather than outside providers assuming that you knew what you knew, which is very different than when you're a physician. They assume you know a lot, and it may be later that they find out that you don't know as much as you knew. They thought you knew. I'm kidding you. But I mean, I think that is a distinction by role definition and perception. So, so that, yeah, I think those were probably the major barriers.
Where do you think the field's going? What do you think?
In movement disorders? Or
what will this meeting be featuring 10 years from now?
I think it will be featuring a lot more technology. And I think there'll be a lot more technology that's used in less monitoring sense, but more human interaction sense. So I think that technology will be...
You're talking about robots?
I'm talking about all kinds of things. I think there will be robots, and I think there'll be a lot of sort of virtual things. I think we'll be doing a lot more in a form of telemedicine that we can't even conceive of right now. You might be like Google Glasses, where you're interacting with your clinician any place where you might be. I think there'll be, and I also think, hopefully, that this meeting will have basic scientists that have, like we have some neuroscientists that are physical therapists. I hope we have basic scientists, neuroscientists that have other kinds of discipline backgrounds, because there aren't very many right now, and that and then I hope that there's much more collaboration across disciplines in this particular meeting. What about you?
Well, I think that in 10 years that we will be trying to figure out how to use drugs which actually alter the progression of the disease rather than simply treat the symptoms. And I also think that there may be a lot of advances that take place that really come from what it seems like subtle changes in how you manage patients. But and this is going to come out of registries like the NPF and so forth, and that is going to lead to a substantial improvement in care of Parkinson's disease and other disorders as well. I think the tough question will probably be cognitive function and ways to prevent
Yeah.
cognitive decline. So let me take you back just a little bit, see if you remember this. I mean, as you mentioned earlier, surprise is often a kind of a wonderful thing, and both clinical care can lead to surprises, and research can lead to surprises. And the surprise that I remember and really enjoy was when we were first starting to work with levodopa and intravenous levodopa. And we had a patient who had come in who was a logger, a big muscular guy, who talked and had Parkinson's disease, who talked about having Big Mac attacks. And his Big Mac attack would be he would go to McDonald's, buy the biggest hamburger and French fries and so forth, eat this meal, and then not be able to move for several hours. And we had figured out at that point that it was all had to do with gastric and absorption of the drug. And so we brought this man into the hospital, and I told him that he was going to be able to have a Big Mac with no attacks whatsoever. We hooked him up to intravenous levodopa. We got the hospital to come up with the closest thing they could come up with to a Big Mac, and had the nurses served it to him. I told him that he could eat this with impunity. He should not have any problem. Watched him dig in with great joy, and went back to the office. And about half an hour later, I got a call from the nurses saying that my patient was frozen, couldn't move at all, and I was astounded and could not figure out what. Do you remember?
I remember the Big Mac attack, but I don't remember the end of the story.
Well, the end of the story was, in talking to, and I think particularly to Bill Woodward, we started wondering, well, maybe getting the drug into the body is not the only thing. You need to get it into the brain. And that's when we kind of tumbled to the effect of protein on getting levodopa transported into the brain, where it becomes dopamine and is effective. This same gentleman, though, at the end of his hospitalization, he was in the clinical research unit. He was asking the nurses whether he could get a couple bottles of levodopa to take with him so he could go elk hunting.
So, Jay, what do you think the MDS Society will be like in 10 years?
That's when we will have the therapy that slows progression of disease. I think that what is going to happen with the society is that it is going to continue to open its arms to more and more both clinicians, scientists, and other people throughout the health field. And I think that the care of Parkinson's disease and other diseases will markedly get better. And I think as collaboration develops between other subsets of healthcare delivery, or the people that are delivering healthcare, will continue to grow and will result in even better care for patients.
If you were going to turn the clock back 20 years, what would you do differently in your career?
I wouldn't do, I don't think I would do anything markedly differently. There are some studies now that I can look back on that weren't very rewarding, could have done without. But I think that the growth of our program and both the research and the clinical care, and I think the education. And I do think one of the really important things is trying to educate people that are outside of movement disorders and telling them about Parkinson's disease and trying to get other scientists interested in Parkinson's disease. And oftentimes just having a group of patients that are willing to participate in studies is something that will attract other scientists because they can get samples or do studies or whatever. So I think I think as we educate more people about Parkinson's disease, we'll develop more research.